Hello, everyone. I hope you're all enjoying Migraine Awareness Month. There's lots of chatter about the new CGRP medications. So to help us understand them, we've got Dr. Richard White from Townsville today, who's a neurologist, who's going to talk to us about them. How are you, Dr. White?
I'm very well, thanks. Good morning.
That's good. Let's start with the new medications that everyone's talking about. Can you explain what these new medications are and how they work?
Well, CGRP is a molecule which has been identified and understood to have some role in chronic head pain and specifically migraine for quite a while. It stands for calcitonin gene-related peptide, and it's a neuropeptide, so one of the body's messenger molecules, and it's present in the venous blood of the jugular vein in people who've got headache in very high quantities, and we've known that for some time. And we understand a little bit about some of the things it does, and it modifies pain sensitization and pain processing in this system we call the trigeminal nociceptive pathway, or trigeminovascular system, which is a key element of how migraine is generated and maintained. And probably in the early noughties, the first evidence that you could do something to block this molecule and help migraine was published. But those first medication suggestions were potentially a little toxic. So it's taken some time to develop what we have now. And there are, I think there are four, only three of whom have been licensed in Australia, compounds which are different to the normal molecules that you get prescribed from a doctor, which are pharmaceuticals, which are usually quite small in structure and taken as tablet medications and metabolized by your liver. These are more complex compounds, which we call monoclonal antibodies. And that means that these are drugs that are synthetic. They're small proteins, and they're very similar to the proteins that your immune system makes when it's attacking something like a virus. But in this particular situation, the molecule is targeting either CGRP itself, which at least two of the drugs do, or the receptor for CGRP. And these drugs are given as a subcutaneous injection. And once they're in the body, what they do is bind to either the receptor or CGRP and prevent it from doing what it does. And the benefit in migraine has been a reduction in headaches in people who are sensitive to those medications.
What kind of migraine is this treatment appropriate for?
Well, the evidence that they're helpful is present for both episodic migraine and for chronic migraine. I'm not aware of any major differences in effectiveness between people who've got aura and without aura, but it's important to stress that it's as in many medications that are available for migraine, the strongest evidence is in regard to migraine pain rather than some of the other phenomena that we see. The licensing, I think, in Australia includes episodic migraine, but the major use for these drugs is almost certainly going to be for those patients who've got chronic migraine, which is migraine where the migraine days are almost impossible to distinguish from the non-migraine days. There's a constant background head pain.
This is a question that's a little off script, but does it work for like brainstem migraine or hemiplegic migraine as well?
The numbers of patients that have been studied are very small, very, very small. When you look at the clinical trials compared to some of the cardiac drugs, so when someone does a drug like a statin, often the clinical trials will be tens of thousands of patients. But the evidence in these is a much smaller cohort of several hundred, a few thousand, I think, in total for all the patients in all the clinical trials of these drugs. And it's not possible from that to make a scientifically valid statement about, look, it works particularly well in brainstem aura or hemiplegic migraine. There are very good reasons to suspect that it would, and there are some non-migraine head pains that are very disabling as well, like cluster headache and hemicrania continua, where CGRP levels may also play a role. So it's almost certainly going to be the case, and I think for at least one of the agents, there has been some evidence in cluster headache. It's almost certainly the case that they're going to have a role which goes beyond migraine, but we're still feeling our way, and we're in that post-marketing phase with the new drug where we're now understanding how we translate research into clinical practice. And as we grow and use it, we'll undoubtedly start picking out the hemiplegic migraines and the brainstem migraines, and begin to see whether there's a differential benefit.
What kind of response is considered a good response for these medications?
Well, we usually judge the effectiveness of a migraine medication by counting migraine days or migraine painkilling use whenever you do a clinical trial, because that's something that's a bit more objective and countable, because it's quite difficult to measure some of the symptoms in migraine because they're so subjective. And when you're trying to do something which is scientifically valid so that you can communicate that to other doctors and patients and give a meaningful answer, you need something that allows itself to be counted. So it's usually based in terms of migraine days or migraine severity. And whenever the trials are set up, they're usually set up as the target that we aim to reach is a 50% reduction in those parameters. And that's what we see with these drugs when they work. It's important to stress that, as with all medications for migraine, we're sadly not dealing with a cure. We're dealing with an agent that reduces the burden and reduces the amount of suffering. People respond to them to a variable degree. If you have a greater than 75% response, we might refer to that as a super responder. And about 10 to 15% of patients on the CGRP antagonists fall into that category. And when you meet them, it's really quite striking. And I've had a few patients that have fallen into that category even after very lengthy periods of their life suffering with migraines. And it's always very impressive and validating as well for both the patient and the science. But more realistically, about a 50% reduction is achievable in 50 to 60% of patients overall. If
you get some benefit from these medications, but still have some breakthrough attacks, can you combine them with other older therapies?
Yes, I don't think there's any reason to be concerned that they wouldn't work. Whenever you're combining medications, the concern for doctors and should be for patients is drug interactions. Because these are not metabolized by the liver or the kidney in the way that normal pharmaceutical medications are, we don't worry about that kind of interaction. And there is a good argument to make for sort of a logical polypharmacy approach, or using a medication that works on one aspect of your symptoms. So the CGRP antagonist help with your pain and reduce the underground background level of aggression of your migraine, but you can use an anti-sickness medication on top of that to deal with nausea when you get episodes, and there shouldn't be any interaction there. And the preventative medications like topiramate and Endep, azotifen, valproate, sandomigrine, whatever you're using, they should work. They should be usable as well. Although I suspect that for a lot of people that will be prescribed these medications, they will already have been individuals that haven't responded to those, and may well be looking at working with their neurologist at pruning back some of those medications. But I certainly don't see any reason why you couldn't co-prescribe those medications or use them comfortably.
We know that you can't get Botox injections or Emgali on the PBS at the same time as part of the restrictions on the subsidization. Are there any clinical concerns about using both?
There's some reason to think that the two agents might actually be synergistic. Botox works on the C fibers, if memory serves me correctly. It has a number of complex effects on trigeminal pain processing, and the CGRP antagonists seem to have more of an effect on, we call it, I think they're A delta fibers. So there are two different types of sensory nerve fiber involved, and people have argued that using the two drugs together might actually be synergistic. The downside is that because part of the effect of Botox will be its own effect on CGRP levels, so Botox might also affect how CGRP is released and how it's handled. And then we're using CGRP blockers as an additional thing. Well, maybe by using the two together, we will get an excessive reduction of CGRP, and maybe we'll have some adverse effects because of that. And it will take some time in clinical practice to answer that question. Looking at the effects of CGRP antagonists in clinical trials, we seem to have relatively few side effects, and Botox seems to have relatively few systemic side effects. This may be more theoretical than than realistic, but there have been concerns because CGRP has an effect on blood vessel tone that it might have more diffuse cardiovascular effects. Obviously, botulinum toxin effects is largely confined to where you inject it, which for migraine will be neck and scalp. So if you did see some excessive effects on the circulation, it should be confined there. And that might affect, for example, wound healing. No one's really seen any signal of that yet. And it takes time for clinical evidence to accumulate. And this will be difficult work to do because I don't think either the manufacturers of the CGRP antagonists or Allergan are going to be particularly keen on putting their drugs head to head. I think it's going to take some post-marketing surveillance and empirical experience in migraine centers before we start really getting a handle on just how effective that combination might be, but also whether there are any adverse effects.
That's all the questions I have for you today. Do you have any additional comments you'd like to add?
No, I mean, just it's exciting times to be practicing in this area because not only are these CGRP antagonists that we have now promising much, but looking ahead over the next few years and related to further neurobiological insights into trigeminal system and CGRP and CGRP handling, we may have other medications coming, some of which may be oral. So yeah, look, it's a time for some optimism. Unfortunately, it's not the panacea we hoped for. And my experience of prescribing these medications is that in common with really all the medications we prescribe, you will encounter patients who don't respond as well as you would like. And I think you have to have realistic expectations of what the medications can achieve. If you go into using these medications hoping for complete cure, you're bound to be disappointed. But if you're looking for improvement of quality of life and reduction of days, then that's certainly achievable for most people, but you may have to work through things systematically with your neurologist.
Well, thank you very much for joining me, Dr. White. That was very helpful. Lots of very clear answers to those questions, and thank you very much.
My pleasure. Take care. See you.
Bye.